Commit your work to the Lord, and your plans will be established. Proverbs 16:3. I hope that things are going well for you. Today, we are going to look at Lecture 2 of the urinary system, and we'll cover the physiology of the kidney, primarily glomerular filtration. It is not an easy word to say, glomerular filtration. This is the heart and soul of how the kidneys work. So this is highly important. There are three processes: glomerular filtration, tubular resorption, and tubular secretion. Glomerular filtration, tubular resorption, and tubular secretion. And I'm going to try to write on this with my pen. And let's see if this works. So glomerular filtration is going to produce the filtrate. Tubular reabsorption is going to return most of the substances from the filtrate to the blood in the renal tubules and collecting ducts. Okay, notice 99%. 99%. Tubular secretion is secreting. In other words, a few substances are selectively moved, secreted from the blood to the filtrate. So reabsorption, we're going from the filtrate to the blood. Okay, from the filtrate to the blood. Whereas in tubular secretion, we're moving from the blood to the filtrate. From the blood to the filtrate. Got to keep this in mind because it gets a little confusing down the road. So here are the processes. Right. Remember the glomerular capillaries. This is where in the glomerular capsule, this is where filtration is taking place. So the renal tubule and collecting ducts that contain the filtrate, the peritubular capillaries, and notice that we have secretion going from the peritubular capillaries back to the collecting ducts and the tubes. Okay, so remember that. Remember that that's secretion. So the three steps, when you look at the three steps, all right, you've got glomerular filtration, tubular reabsorption, and tubular secretion from the blood back to the collecting ducts. Tubular reabsorption is movement of molecules, water, back into the blood, So let's look here. Filtration is passive. Filtration is passive. This is very important. What does that mean? It means you don't use up ATP. The pressure coming out of the afferent arteriole is going to force fluids and solutes into the glomerular capsule. All right? Remember, the pressure in the afferent arteriole is much higher than the pressure in the efferent, and that causes hydrostatic force. There's no reabsorption in the capillaries in the glomerulus. So remember that the membranes between the blood and the interior of the glomerular capsule, okay, remember that this is the fenestrated epithelium, and the podocytes, they're going to have filtration slits. And so this allows water and solutes smaller than plasma proteins to pass. You should not see plasma proteins in the urine, nor should you see cells in the urine, especially not red blood cells. You may see some squamous epithelial cells that have been shed by the ureter, the bladder, and the urethra, but you shouldn't see blood cells at all. So look at the filtration apparatus set up here. Remember that the afferent is under high pressure. It's going to cause that hydrostatic pressure to be high in order to have filtration take place. Remember that the filtrate is going to move out and into the proximal convoluted tubule. This is a really nice scanning electron micrograph of the podocytes, the foot processes, and then you can see the slits in between that are the filtration slits between the podocytes. This is, stop and think about this. God put this together in such a way that toxins and drugs and waste products would be filtered out, but we would not lose important plasma proteins nor our blood cells. In fact, if you see plasma proteins and if you see blood cells, there's a problem. There's a major problem. So when we look at the filtration membrane, anything that's too big to pass through is going to be engulfed, phagocytized by the mesangial cells. So this means anything that's less than 3 nanometers can pass through. And what are those that can pass through? Water, glucose, amino acids, nitrogen wastes. Anything that's bigger than 3 nanometers and passes through, that means you have a rip, a tear, there's some kind of mechanical problem in the filtration membrane. Why is it important that the plasma membrane stay in the blood? Why? Well, because we need the colloidal pressure to be higher on the blood side than on the filtrate side. This allows water to escape into the capillary system, capsule, and then also it indicates if there's a problem. So what are the outward pressures? What's going to promote filtration? Well, we already talked about the hydrostatic pressure in the glomerular capillaries. And so this is going to push water and solutes out of the blood into the capsule and eventually to the proximal convoluted tubule. The inward pressure, so what's going to inhibit filtration is the hydrostatic pressure in the capsule and the colloidal pressure in the membranes, in the capillaries. But what we see is that the net filtration rate, is going to decide how well filtration takes place, so that the main controllable factor determining glomerular filtration rate, okay, is the net filtration rate. And knowing the glomerular filtration rate, we can tell how well the kidneys are working. Here we see that the net filtration pressure is plus 10. In other words, we have things moving out of the blood and into the filtrate. The glomerular filtration rate, okay, is the volume of filtrate formed per minute by both kidneys. Please note that this is both kidneys, right? Both kidneys. And it's directly proportional to the net filtration rate, the total surface area available for filtration, and the filtration membrane permeability. So if I were to ask a test question, I might ask you, define the glomerular filtration rate. And you would say the volume of filtrate formed per minute by both kidneys. Both kidneys. I might ask you, is the glomerular filtration rate directly proportionate to or inversely proportionate to the net filtration pressure, the total surface area available for filtration, the filtration membrane permeability? And you would answer all three. All three. So what's going to regulate this? Well, we want our kidneys to be constantly filtering the blood, okay? And so we have to look at the intrinsic controls, which is called renal autoregulation. The intrinsic controls, renal autoregulation. And the GFR is going to affect the systemic blood pressure. We've talked about this, but remember that this is going to be the extrinsic control. This is going to be the extrinsic control. So the intrinsic control is going to maintain GFR. The extrinsic control is going to maintain systemic blood pressure. What are the two main extrinsic controls? The nervous system and the endocrine system. Geez, just sounds like something else we just reviewed with the GI tract. Intrinsic controls, we're going to look at muscles, myogenic, and then everybody get ready, tubuloglomerular feedback mechanisms. What? Yeah. Tubuloglomerular feedback mechanisms. Myogenic is basically the little smooth muscle, that is going to restrict the blood flow from the afferent arteriole into the glomerulus. Okay? You wouldn't want your blood pressure to be so high that you blow up your little glomeruli. That means you would have no more filtering. And sometimes this is what high blood pressure does. When we talk about high blood pressure and kidney damage, those little glomeruli just go pew, 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 and you've got no filtration left. So these are going to help maintain normal GFR. Okay? Tubuloglomerular feedback is going to be directed by the macula densa. Now, we talked about the macula densa cells in the first lecture. If you need to, go back and review. So if the filtrate flow increases, that means that there's not enough time to reabsorb sodium and chloride. And so there's a high sodium chloride level in the filtrate. The macula densa senses this. It senses this and provides a feedback mechanism that is going to lower the net filtration process and the glomerular filtration rate, and that allows more time for sodium and chloride to be reabsorbed. If the filtration rate is too high, then the opposite things take place. All right, you might want to take a break, stretch. Extrinsic controls, neural and hormonal. Remember that neural controls, we've got sympathetic and parasympathetic, and what we see with sympathetic is that blood is going to be shunted from the internal organs to the skeletal muscles in order to fight or flight. So when we're at rest, that's the parasympathetic, the renal blood vessels are going to dilate, and we'll see, autoregulation take care. Under abnormal conditions, then what we see is norepinephrine and nephrine are going to be released, and this causes vasoconstriction. That's going to increase blood pressure, and that's going to constrict the afferent arterioles, and that will decrease the glomerular filtration rate. So what we see is a decrease in glomerular filtration rate, which means there's more blood for the muscles to use in fight or flight. A very, very, very important mechanism is the renin-angiotensin aldosterone mechanism. And this is the main mechanism for increasing blood pressure. And remember, there are three pathways for renin to be released by the granular cells. Remember, the granular cells are the JG cells. And so we have here, we're going to have direct stimulation of the JG cells by the sympathetic nervous system. We're going to have stimulation by the activated macula densa cells when the sodium chloride filtrate concentration is way too low. And then stretching of the JG cells is what keeps everything flowing in the right direction. But if the JG cells aren't stretched enough, you have reduced stretch, then the renin-angiotensin aldosterone mechanism is going to click in. So here we have figure 2514, and this is the regulation of the glomerular filtration rate in kidneys. Please note the myogenic mechanisms, the tubular mechanisms, the hormonal mechanisms, and the neural mechanisms. And remember that the renin-angiotensin aldosterone mechanism is very important. So here is a very important table. Let's draw a star. Talks about the intrinsic controls, the renal autoregulation, and the extrinsic controls. What is their purpose? What is their mechanism? And that's really important, the purpose and the mechanism of each. So let's talk about what happens if filtration doesn't take place. And this is called anuria, all right? Anuria. Some people pronounce it anuria. I was taught to pronounce it anuria. Whee! Anyway, so very low urinary output, less than 50 milliliters a day. Oh my goodness. Then someone ain't peeing. They're either incredibly dehydrated or the blood pressure is too low, or the could be that some infection is clogging up the nephrons, causing acute nephritis. Could be that if there's a transfusion reaction and all that hemoglobin is clogging up the filtration slits. And then, your kidneys get squished. Yeah, that's not good. Squished kidneys, not good.